Hello everyone, this is an effort to give you guys more questions to practice while you're studying for your step 1 examination. So let's just start. We have a 25-year-old male comes to the emergency department with complaints of food impaction. Physical examination shows pulse of 78 beats per minute, blood pressure of 120 by 80 and respiratory rate of 16 breaths per minute. Endoscopy was done and the food particle was pushed down into the stomach with linear furrows observed. Post-operatively, patient denied of having any previous complaints of heartburn. Which of the following changes are most likely present in esophagus? A. Infiltration by granulocyte. B. Mucus secreting cells. C. Multinucleated cells. D. Intranuclear and cytoplasmic inclusions. So this is kind of a boring way to read the question. Now let's see what's an interesting and how to paraphrase the question. So how you should read is actually we have a young male that is coming to emergency department with a complaint of food impaction. His vitals are stable. Now that required removal or pushing down the food bolus into the stomach by endoscopy. And while doing endoscopy, linear furrows was observed. Now, the patient was post-operatively asked if he had any previous complaints of heartburn. That is, if he had any previous complaints of symptoms related to gastroesophageal reflux disease. And the question asks what might be the likely thing that is present in the esophagus if we do a biopsy, assuming that. So let's see what are the actual clues in the question that might tip us off into answering this question. Now, I have highlighted food impaction, linear furrows and denied heartburn. So these are kind of the buzzwords that you should remember for answering the questions that would be related to the answer that is present in the question, which will be on the next slide. So the answer says infiltration by granulocyte. Now you might think that granulocyte can be either neutrophils, basophils or eosinophils, but the point over here is to answer the best possible option that is present in the question. So if you think that eosinophil is actually a kind of granulocyte, so that is where I'm getting at. Now let's see the other options mentioned. B. Mucus secreting cells. Now do you think this guy might have his distal esophageal lining replaced by some mucus secreting cells like goblet cells? No, because he already denied that he did not have any previous complaints of heartburn. So this option is not likely going to be the right answer. Now what's Barrett's esophagus? You guys must know this, and I am sure that everybody knows that it's an intestinal metaplasia that is present in the distal junction of the esophagus, right? So multinucleated cells. So and D, these two would be likely present in a person that is having a CD4 count of less than 100, and this would likely be an HIV patient, right? So this you guys must be absolutely aware of, that multinucleated cells are observed in herpes simplex virus type 1 and intranuclear and cytoplasmic both are observed in cytomegalovirus. Now let's see what's actually eosinophilic esophagitis is, and what you should remember about this topic is it is characterized by infiltration of squamous mucosa by eosinophils with a history of atopic conditions like eczema, asthma, allergic rhinitis. So these are basically hypersensitivity type 1 kind of reactions that are present with that goes with the history of eosinophilic esophagitis, which would likely present of food impaction that would require the removal by endoscopy. So if they mention in the question that it required removal by endoscopy, it is short eosinophilic esophagitis. Now gastroesophageal reflux disease should be ruled out because EOE is associated with it, and the treatment options would differ. If the patient had a previous complaint of GERD, we would start the patient on PPI, that is proton pump inhibitors. Or if the patient is simply having eosinophilic esophagitis, we would likely opt for steroids and mast cell stabilizers. Now I have tried to simplify the pathophysiology of it, though it is not so clear. But let's start. What initiates the impaction is the allergic substance, which is the antigen that is present in the food that we are consuming. So what happens next is the antigen gets taken up by the antigen presenting cells, and they go to the nearby lymph node and give it to the naive T cells. Now naive T cells, what they do is that it stimulates the differentiation of Th2 type of lymphocytes. Now this lymphocyte, if you recall, gets stimulated by the interleukin IL-4. Now Th2 lymphocyte will further release an interleukin, that is interleukin 5, and that will lead to the stimulation for class switching of the B cells from IgM to IgG, and then it can also lead to IgE. So IL-5 is the trigger for eosinophils. Now these gets recruited in the esophagus. Now what does eosinophils do is they release major basic protein. Now MBP is shown to activate the mast cell degranulation. So this is the possible pathophysiology of eosinophilic esophagitis. Now let's see what actually endoscopy view looks like. Now you guys can see these are linear furrows. Alright, there's a difference between linear furrows and linear ulcers, which you would be finding in cytomegalovirus infection of the esophagus. That would be most likely a patient of HIV, right? So this is what the endoscopy view of eosinophilic esophagitis looks like, and you guys should be prepared to get this kind of questions on your boards because they would likely show you these pictures. Now these are the characteristics finding. Now it may be presented to you like linear furrows having multiple concentric rings or webs. Now this may be called trachealization of esophagus to confuse you. Now let's compare. On the left side you have the esophagus that is having this multiple concentric rings. See, and on the right side you have the actual trachea. So you guys can compare and contrast this. Both the pictures looks similar to you, so do not get confused if they tell you that this is having a trachealization. Alright, so then next thing, now this is kind of a quiz, small quiz to quiz you guys on knowing what endoscopy finding of the infection would most likely look like. So you have whitish pseudomembrane and whitish exudates over here on an erythematous base. So what's this most likely? Yeah, you guessed it right, this is candida. So now these are the three main important points that I need to tell you guys. Is oral thrush in a baby does not mean that the baby has HIV. He might have gotten it from the mother birth canal, so don't assume that the patient is having HIV unless they tell you that the mother had a history of human immunodeficiency virus. Okay, so oral thrush in adults, think AIDS or immunocompromised, that can be secondary to a steroid therapy or a chemotherapy for leukemia, right? So these are pre-AIDS defining lesions, not a confirmed case of AIDS but surely immunocompromised. But candida in esophagus is short AIDS, right? And the CD4 count would be less than 100. I have confused it over with 200, so pardon me for that. Now the second picture over here is we have ulcers, right? I bet this guy must be having a hard time swallowing any food particle, so this patient would likely have odynophagia. And if I tell you that this is a patient of AIDS, what you should immediately think of is herpes simplex type 1, right? You guessed it right. This is a typical punched out ulcer that you see in a patient of HIV if you do an endoscopy. Then the third one, you can see some red erythematous linear ulcers that are present in the esophagus. What infection might this be? Let's see. Okay, yes, that is CMV, cytomegalovirus. Now I have given you some endoscopy pearls that you should keep these things at the back of your mind, because these things are actually going to tip you off into answering and picking the right choice in the questions. So eosinophilic esophagitis would have a linear furrows and have an infiltration by eosinophils. Compare this with cytomegalovirus, which would actually have an ulcer, linear ulcer, right? And herpes simplex virus would have a punched out ulcer, and that would have a multinucleated cells if you biopsy that mucosa. And mallory weis and borhaave syndrome are the two ends of the tears that you can have in the esophagus. This is a partial tear, and borhaave is a transmural full tear, which you would be detecting on a CXR by seeing the air under the diaphragm, And candida, we already saw that it would have a white pseudomembrane. So guys, let me know if you find this helpful, and I'm open to constructive comments. If anything in this video is wrong information to you, please let me know. I'm here to help out a community. Thank you guys. See you till next time.